Good morning. We are here at Azusa Pacific University, and we are creating this webinar for you today on obesity and new strategies for better management in primary care. We're going to focus some on motivational interviewing, more specific assessments, and some other tools that we really hope will help you to get better outcomes for your obese clients in the primary care environment. My name is Dr. Linda Reed. I'm chair of the Advanced Practice Nursing Program, and this is Dr. Anna Hefner, who's going to lead us today. Good morning, Anna.
Good morning. Okay, so I've been asked to talk to you about obesity. And obesity is kind of a touchy subject for most people. First, they don't want to admit they're obese. They don't want to admit they're overweight. And what are you going to do about it? And so that's what we're here to talk about today. So the first thing is I've come up with 6 objectives for you. One is to articulate your role as an advanced practice nurse. It's to tell you how are you going to take care of that kind of patient. How are you going to evaluate them based on a history, a physical exam, and diagnostic reasoning. It's going to talk about how to motivate patients and what is that they need, because you just can't say you need to lose 10 pounds. It just doesn't work. All right? We need to describe weight bias and how it affects the obesity treatment plan. And we need to assess current eating patterns and exercise and personal preferences. And then we need to identify the current practices and resources for providing care for the obese patient. So the first thing is just to really define what obesity is. And obesity is defined as a chronic, relapsing, multifactorial, neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in the adverse metabolic, biomechanical, and psychosocial health consequences. Those are a lot of big words, and it really is that the obese patient has a lot of issues that occur to them. There's metabolic issues. We have to talk about diabetes. We have to talk about cholesterol issues. We have to talk about just weight in itself. We need to talk about how does that affect other people associating and talking with you. Do they like obese or they don't like obese? Is your family obese? Is your family not obese? What kind of environment have you placed yourself in? And we also have to just talk about how does fat work? Because somebody can eat as much as they want, whenever they want, how much they want, and they stay skinny. And you look at the blueberry muffins that we have on the counter and you've already gained 10 pounds. Okay? It's just how life works. So the terminology that we have to talk about is really important to the patient. We don't say the obese patient. We say the patient with obesity. So now you're a person and you have a disease, not that you are a fat person, because that turns everybody off at that particular point in time, so we don't get to. We need to talk about encouraging terms. Oh my gosh, it looks like you've lost a little bit of weight. It looks like you have more energy. Looks like you've slept better. And so those are the kinds of things that we have to look at to make the patient feel better about themselves. We're going to talk a little bit in a few minutes about obesity, and I tell my patients, I don't want you to lose any pounds for 9 months. And they're like, but I'm here for obesity. Yes, but we want you to lose inches first. Because that's what you do when you start to change diet habits, is you lose inches, you don't lose pounds. And then you come in and you weigh the same, or you've gained a pound, because fat weighs a little bit more than not fat. Or muscle weighs more than fat, and then they're going, but I'm gaining weight. I guess this just isn't it for me. I guess I don't need to come back. No, you've lost a half an inch. Perfect. That's what we want you to do. We talk about weight. I don't say, well, you're fat. I do to a couple of patients because that's what they tell me to tell me that I'm fat. Okay. I don't like using those words, but that's what they want. We have to look at for unhealthy weight. Unhealthy weight could be too little weight or too much weight. So it goes both ways. If you're overweight, we look at body mass index, and we have what is affected by obesity. When you come in and you say, look, I'm just so tired. I just can't do this anymore. Can we just sit here and talk? My cholesterol, my glucoses are only 400. Okay, this is what we need to talk about today. Okay, let's talk about your diabetes. Even though that's going to affect your obesity, I'm not going to talk about obesity. I'm going to talk about diabetes today, because that's what's impacting what you're doing today. All right, prevalence of obesity is our Hispanic patients tend to have high obesity rates. They tend to be plumper. Okay, and part of that is cultural. Being overweight says that you are wealthy. That's an interpretation that they see. African, non-Hispanic, Black, African Americans are also overweight. They like the big bottoms. That's a status symbol to have a big bottom. Big boobs, big bottom, so it's okay. Non-Hispanics are 12%, non-Hispanic whites are 37%. They're still all overweight. But there are cultural implications that we have to deal with when we talk about this as well. And we'll get into that. So objective number 1 is, what is your leadership role for advanced practice nursing in the care of the patient who is overweight and or obese? Now, all in primary care, you get lots of these patients. I'm in hepatology, liver disease. I get your patients as well. I get them because they've been diagnosed with fatty liver disease, which is an association of obesity. It's all part of this metabolic syndrome. Okay, we used to call it metabolic X, now we call it metabolic syndrome, so we know what we have. So we are, as nurse practitioners, the front line. You bring a patient in, you look at the BMI and it says 35, ding, 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 they're overweight. They're obese, actually, by definition. So rather than treating his diabetes and his cholesterol issues, we have to do that, but we also have to put that into obesity terms as well. Obesity is the underlying cause of all of this. So if I treat your diabetes and forget to talk about your obesity, then I'm mistaken. I haven't done you a service. I need to make those work together so that we get a better outcome long term for you. We know that 25% of obesity is related to cancer. We know you're at higher risk for colon cancer. We know you're higher risk for breast cancer. We know you're higher risk for endometrial cancer. We know you're higher risk for prostate cancer. We know that. So we've already told you, because you're obese, 25% of you will end up with cancer. So let's change the cancer outcomes for you. We need to take a proactive approach. I don't send you home and say, I need you to lose 10 pounds. Because you go home, you eat really well for maybe 2 days, and then you're like, well, that didn't do anything, so I'm just going to go back and eat what I want. So we really need to be proactive. I take a different approach being proactive. I don't give you a caloric diet. If you go on the internet and you look for a 1,500, an 1,800, a 2,300, a 2,400, a 3,000 calorie diet, look at the foods you have to eat. And do you eat those? No. You don't eat them. You don't like hot dogs. You don't want this. You don't want that. You don't like whole grain bread. You don't like apples. You like oranges, whatever it is. So my approach when I do this is I say, tell me what you eat. And we'll get back into that in a few minutes again. But I tell me what you eat and we'll fix what you eat. Because that's what you're going to eat. You're not going to go out and spend all this money to buy this new diet that you're only going to do for 2, maybe 3 days if I'm lucky. And then maybe on day 7 you'll do it again. And because the food's going to go bad if I don't eat it. And then you'll eat that plus your food. And we haven't solved our problems. The role of the advanced prac nurse is to really understand the model of obesity. It is not something that somebody goes out in life to do. You don't start as a 2-year-old and say, I'm going to be an obese adult. That's not what you do. But you need to understand that it is a product of an environment. It is a product of your genetics. It is a product of your physiological responses to things. And it's a product of all the medications you've been prescribed. So there's a whole lot of other impacting factors with this. Now, I can teach you how to do certain kinds of things. I cannot change your genetics. I just can't do it. You are who you are, and I have to work with that. I can change a little bit of your environment by making you aware of your environment, not by moving you out of your environment, because I can't do that. Physiologically, I can do some things that will help you digest food better. But I can't change a whole lot of your physiology as well. But putting it all together, I can make you a better person as far as weight. All right? I can conduct screening and work up for obesity, including the identification of complications. So when you get an obese patient, you should be doing a hemoglobin A1C. You should be doing insulin, a fasting insulin, to see if they're insulin resistant. You should be doing a cardiac workup in some respects, an EKG, looking at their CPK, looking at uric acids. So looking, again, you're looking at renal disease, so you want that CMP because you want to see what those BUN and creatinine is doing. You want to see what those liver enzymes are doing. You want to see this big picture. And then from that big picture that you have, now you can start working with your patient. And again, remember, we have to do fasting lipids. getting lipids without making them fasting doesn't give you any good results because you can't treat a non-fasting lipid. It's like, well, was it because he just ate the pasta or was it because he really has high cholesterol? All right? And then we have to initiate productive conversations with the patients about their weight. And that is only when the patient's ready for that. Not all patients are ready for that on the first you go. Okay, we have to develop a plan of care for you. So what are we going to do for this? We ask the patient, what do you want to do? So in front of you right now, you have a paper that has some pictures on it. I would like you, you're all female, so you're going to use the female model. I want you to mark an X where you currently are on that diagram. Where do you think you are? Then I want you to circle where you'd like to be. And it can be the same thing. Now I would like you to put a dot over the male figure of what you see your father as. And I would like you to put a dot over where you see your mother on the women. And most likely you fit somewhere in there between your mom and your dad because you are a genetic product. You are an environmental product. You eat what your mother cooked and put in front of you. Some of you had to eat more than what your mother put in front of you because she gave you a plate that says you must eat everything on your plate because of the starving children in Africa. Okay? And we've all lived those kinds of things. And you may be doing the same thing to your children. All right, we're going to come back to that diagram. We have to facilitate patient self-management. What would you like to do? You've marked down that you're an 8, and you say that you'd like to be a 3. So how do you think you would like to get down there? They can say exercise, they can say changing their diet, they can say, I want some magic pill. They can say whatever, but that tells you a little bit about your patient. It gives you a place to start on how to help them get better. You know, I'd like to walk 3 miles every day. Okay, so how do you think what do you do? What's a typical day like? Well, I get up at 6, I have to feed the kids, I got to get them off to school, then I have to come home and get ready for work or school, then I go off to school, then I come home and we got to get dinner and we got to get all the activities the kids have to do, and I hopefully get a load of laundry put in. And hopefully remember to put it in the dryer so I don't have to rewash the clothes I just did. Okay? Okay, so when do you think you can fit in a walk? Well, I don't know. Well, when you take your child to soccer practice, how many kids do you have? I have 3. What do you do with the other 2? Well, we just sit on the bench. Why not walk while you're there? Oh, I never thought of that. You don't have to walk fast. You can just walk with your kids. Or I have one other child who we sit and do homework. Okay, have you ever thought about doing homework walking? Where you chit-chat about your homework and then you stop and then you do a few problems and then you chit-chat some more and do some more problems? No, I hadn't thought about that. Have you ever thought about taking your 11-year-old or 12-year-old for a walk and just talking? Or not talking? Or your 13-year-old who doesn't want to be seen with you anymore? Okay, but have them go for a walk. If you have your children in, I'll say, how would you like to go for a walk with mommy or daddy? Oh, I would like that. Okay, here's the rules about it. You need to walk in front of them at your pace. You may not run, and you may not, when you get to a corner, you must stop and wait. If your mother or father is more than one house behind you, you must stop and let them catch up. So you give parameters to the kid who now thinks he's got control. You have a mother who's happy because she's out with her child, and she's now walking. And she's walking faster to keep up with her kid. Now, you can't do that with a 4-year-old because they won't stop at the corner, okay? So you have to do this all within reason, and you have to think about it. But again, you can provide ways. This is what she wants to do. Let's find some ways for her to do it. Things that are out of the box that you might not think about. Let's see what else we have. We have coordinate care among patient community resources or other healthcare professionals, including obesity specialists if needed. I'm the primary. That's what most of you are. I'm not a primary. I'm a specialist. But if I was the primary, I need to know what's available. What is the Senior Citizen Center holding classes for elderly people because I have an elderly patient? What does YMCA, if YMCA is in my area? What does after-school activities provide? You know, it means you have to go to the Parks and Recs or the City Hall and get a copy of what's going on that semester or those few months, winter, spring, summer, fall, however they put it out. Why? Because you have to be an active participant to help them. They may look at this book and it goes in the trash can, don't have time for this. But then they may have things that they can do. They're home during certain hours, so they could go and do it. Even if they went exercising 1 day a week, it's better than not doing any at all. Okay, and a lot of it is free. Address billing procedures to support your obesity practice. There's lots of codes, and we're going to get into codes, and I have some more codes that we can add to that in a little while. All right, objective 2 is evaluate patients affected by obesity-related complications using a health history, physical exam, and diagnostic reasoning. It's the impact of choice of words that has an impact during your clinical evaluation. So tell me what you do in a day. That's very generic. It's not saying, are you sitting around watching TV eating ice cream all day? Okay? But tell me what you do. Tell me what you eat. Tell me what time you eat. That has an impact on obesity as well. Okay? So you're going to do those kinds of things with them. How do you sleep? As a nurse practitioner, that's one of our review of systems is sleep patterns, and yet we never do it. What time do you go to bed? What time do you get up? How many times at night do you get up? Oh, I get up 4 times. What do you get up to do? I get up to pee 4 times. Ding, 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 diabetes. Ding, 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 cardiac disease. Something's going on. Why? Because when you lay flat, you perfuse your kidneys and your heart works better, and therefore you pee more. What else is going on to do that? Okay? Something you hadn't even thought about. Okay? One more lab test I have to do, insulin resistance, diabetes, and hemoglobin A1Cs. So you talk about what they do, how they sleep. When do you eat? Why do you eat? I eat because I'm just on the run, so I go to McDonald's. I drive through McDonald's every day because I'm on the run. Well, what do you get at McDonald's? Well, I buy their Coke. I buy their large Coke. Diet or regular? Regular. Why do you buy a large? Because it's the same price as a small one. Okay, you can get them all for $1. So big is better, right? What else do you get? I usually get French fries because it's quick and easy, and sometimes I get a hamburger. I don't really like their chicken nuggets. And if you get the Big Macs or the Quarter Pounders, even though they're probably better for me, I really can't eat them because then they slop all over my clothes because I'm eating in my car. Perfect. Got a big, huge clue. Okay? Do you ever have family meals? Don't say you have family meals, right? Because now you've said they're supposed to. Just say, do you ever have sit-down meals with your kids and your husband or your parents or whatever? Do you ever have a day that you guys everybody has mealtime? Again, you're just gathering information because you can use that information to help motivate them as well. All right? So again, choosing your words. Well, I just want to get you unfat. Probably not a really good thing to say to a patient. Okay? BMI is your simplest tool. You weigh and you measure them, height and weight, and calculate it out. Plug in the numbers. You don't even have to do the math. Just plug the numbers in. Okay, most of that's done by your medical assistant anyways. If you're not sure, occasionally mine will say she's a BMI of 20, and you're looking like, no, she's not. Somebody must have put a wrong number in somewhere because she's a lot bigger than a 20. And so you just recalculate it or say, she weighed you and she got you at 79 pounds? Okay, well, she might have meant 79 kilos. Okay, because somebody flipped it to the kilos versus the pounds. All right? Modalities to evaluate adiposity is weight circumference. Pick where you want weight circumference. Weight circumference can be just below the ribs. It can be at the top of the iliac crest. It can be where you bend, and that's where your waist is. Okay? In our practice, everything goes at the iliac crest. Everyone can find a bone. Okay? Even on big people, if you push hard enough, you can find that bone. And you measure just on top of that bone so that we're all consistent. Because if you measure it at the ribs, and I measure it at the iliac crest, and you measure it at a weight, we have 3 separate numbers that do not match and will never match. So pick a place, put it in your protocol in your practice. Your MAs can do this, you can do this. Okay, we can do waist to hip ratios. We can do imaging. I can send you off to ultrasound. I can send you off to MRIs, MREs, and get measurements for myself. I can see what it says, how much fat it says. It'll give me a percentage. An MRE tells me you have 17% fat. Tells me you have 48% fat. Tells me you have less than 3% fat. You're supposed to have 5 or less. Okay? But the issue is I can go ahead and measure that by an MRE because I'm looking specifically at a liver. I'm looking specifically at abdominal only. Okay? I can also do body composition. I can send you off for a DEXA scan every 2 years, which you should have for bone density. But you can also ask for measurements. You say you want a fat analysis on it. Now you have to check to see if that facility does that. It means they had to buy a program, load it on their computer, and push a button. I do not know how expensive it is, but they can give you those measurements as well. All right, so we can look at it from that perspective. We can take a weight history. So tell me what you were like a child. How much did you weigh at birth? Most people know what they weighed at birth. Oh, I was a 15-pound kid. Okay, well, you came out a little bit big. Did your mom have something called gestational diabetes? Oh, yes, she did. Okay, well, that accounts for your weight. But then you can say, you know, as a child, do you remember being overweight? Were you the same size as the kids, everyone else? No, I was really tall and lanky, tall and skinny, and then all of a sudden I just blossomed after I had my first kid. Okay, well, that tells you that the obesity hasn't been there for a long time, or maybe it's been there a long time. It tells you, it gives you a pattern of where you need to start. If you've been fat and chunky all your life, that's different than if you've just been chunky for 3 years. Okay? So we have to do that. We want to know your family history. That is why you took that diagram and you told me what you were, what your parents were. If you have a family that's very large and you're large, I'm going to have a harder time to get you to be thinner, because your family is going to be part of this discussion now too. I have a number of Hispanic patients that I deal with, and the kids, they're not kids, they're young adults, have lost a significant amount of weight. And their mothers come in at their visits now and said, what are you doing to my child? She no longer looks like us. Is she too good for us? Well, I never saw that one coming. I said, no, we're making her healthier. But she doesn't eat our foods anymore. She only just takes a little bit as opposed to big plates. I said, okay, so what would you like me to do? I asked them, what do you want me to do? Well, I want her to eat some of our food. I said, she can eat some of your food. She needs to be careful of how much she eats because her liver is suffering. And so we're trying to make her liver better. Oh, do you think I have a bad liver? I don't know, ma'am. We can do some testing on you, but you're not my patient. You have to go to your primary to have your primary refer you here. And then sure enough, they come back, and sure enough, they have fat in their liver, and we have all these things, and so now we're making family changes. Okay? But I have to be very careful, and I walk that fine line when you don't look like your family anymore because they think you're too good for them. Okay? You've taken on the American skinniness. Okay? So we have to deal with those kinds of issues as well. So we do have to look at family history. We also want to know family history of diabetes, and we want to know if your dad died or your grandfather died of diabetes complications, and he was 62. Well, that's pretty young, okay? But he probably had a fatty liver. He was probably a cryptogenic cirrhosis that was complicated with diabetes, and the diabetes is because they didn't understand fatty liver 40 years ago. They said he died of complications of diabetes. So he has what you had, but it wasn't diagnosed with it. A lot of the cryptogenic cirrhoses are fatty livers. Once you get fatty liver and you get cirrhosis, the fat goes out of your liver. The liver shrivels up. There's no room for the fat, but it doesn't work anymore. All right? We have nutritional history. Tell me what you eat. Give me for 24 hours. Now, that's not the best way to get a history. You want long periods of time. But if I asked you what you ate last Thursday morning, not yesterday morning, but a week ago, or what you ate last Friday, a week ago, some of you could say, well, I think I ate this, but I don't really know. But if I say, what'd you have yesterday for breakfast, lunch, and dinner, most of you, probably 95% of you could tell me what you ate. There are a few of you that are like, I have no idea. Okay? Physical activity, what do? I work. Okay, so what do you do at work? Well, I have to go in, I have to work on my computer, so I sit there at lunchtime, I get to go walk to the cafeteria, then I come back. Okay, tells me that you're very sedentary. What do you do on the weekends? Oh, sometimes I clean, but I'm so tired and exhausted, I just sit around all weekend. Okay, that tells me we really don't have any physical activity, or you're the weekend warrior that does everything only on the weekends, which is not necessarily good, or whatever. So when you, at lunchtime, how long do you have for lunch? I have an hour. Well, do you think you could take the long way to the cafeteria where you could walk all the way around? Do you think on the weekends you could walk the walls of your house on the inside? Do you think you could take your dog or your kids for a walk? Things they don't think about. All right? So again, we want them you're supposed to do 150 to 180 minutes a week. If I can get you to do 20 minutes a week, that's 20 minutes more than you were doing last week. Perfect. We're starting. And then we want to know what medications you've been on for a period of time. Insulin causes diabetes. Or doesn't cause diabetes, this is what you're using it for, but causes weight gain. Okay? You put you on glipizide, that's weight gain. Okay, so medicines that we're using to treat other diseases will also cause weight gain. Okay, patients who have schizophrenia who take all of their psych meds, weight gain. Okay, it's part of what it is. So you have to know those kinds of things so that you can work with those kinds of things. I can take you off of glipizide and put you on metformin. I can take you off of insulin and put you on Lantus as long as you're not a type 1 diabetic. If you're type 1, I have to do something different. But I have different medications that I can work with. I can call your endocrinologist. I do not single-handedly do anything. I'm on the phone to your endocrinologist as well so that we can come up with a mutual plan. I still want you to be the endocrinologist. I really don't want to manage their diabetes on a day-to-day basis, but I need you to see if we could switch over to something different. And so I do use those for my benefit. Okay? Oh, and I do call you guys as primaries. I call you all the time. I'm always on the phone to all my primaries. All right? Depression screening. In primary care, you do a PHQ-2. They're either yes or no. If they're yes, then you have to do a PHQ-9. In my practice, I do a PHQ-9 automatically. Obesity has a high risk of depression. So if your patient is obese, you need to do a PHQ-2 every year or a PHQ-9. I would say you have to do a PHQ-2 because your insurance companies require that on all your primary care patients. And then once they have a diagnosis of obesity, I would tell you to do a PHQ-9. All right? We need to see what's their quality of life. Are they happy or are they sad? Are they just thriving or striving to survive, or are they actually thriving? So we want to look at those kinds of things as well. We want to look at your sleep patterns. Okay, for those of you that sleep 4 or 5 hours a night, you probably get up and you're exhausted all day. You want a cat nap, and you do cat nap, and those kinds of things. So we really want you to have a quality of sleep. Can you go to bed at a reasonable time and sleep 6 to 8 hours? Yes or no? And if you can't, we got to figure out why. Is it obesity? Is it sleep apnea? Is it diabetes? Is it stress? Is it the newborn that's waking up all the time for you that you have to get up and feed? So there's lots of reasons for doing kinds of things, but you want to assess their sleep patterns. What happens when you sleep? You repair. If you don't sleep, you don't repair. And the cycle gets more and more going on. All right? So we have to look at what we're going to do. We want you to change. So we need to figure out, prepare. Where are you at? Are you ready to change? Are you motivated to change? Are you just going to not do anything for a while? Because if you're not going to do anything, the best laid plan that I can give you, and you're not going to do it, doesn't help you. It makes you frustrated, makes you don't want to come see me, and it makes me frustrated because you're not doing anything. So I say, okay, you know what? You're not ready yet, so we're going to put you out for 5 months. You keep working on whatever it is you want to do, and then in 5 months we'll reevaluate whether or not you're ready to lose weight. We're all happy. They're like, you're not going to make me come back? No, I'm not going to make you come back. Sometimes I'll put them out for 6 months. Kind of depends upon what time of year it is. All right, because I like to have them in just before Christmas, so we can talk about Christmas cookies. But the issue is we put you, why am I going to spend my time? She's ready to be motivated. She says, yeah, you know what? I'm ready to do it. I think I can do this now. Okay, so where would you like to start? What do you mean? Well, do you want to start walking? Do you want to start eating better? What do you want to do? Well, I want to do all those things. No, let's pick one thing. Well, I think I'll start walking. Okay, I want you to walk 5 minutes every day. 5 minutes? That's all? Yeah, that's it. If you want to walk more than that, you can walk more than that. But I want you a minimum of 5 minutes. Not run, walk. And I want you to walk fast. And I bring them back in a month. How was the walking? You know what? I'm up to like 15 minutes. Okay, so now in that 15 minutes, are you sweating? No. Then I need you to walk fast enough that you sweat for 10 of that 15 minutes. You can go more if you want. I'll see you next month. Then the third month they come back and we say, and she's doing all of that, then I say, okay, so let's look at that diet. Okay, I deal with a lot of Hispanic patients. Okay, tortillas and rice and beans are like a staple. So we eat 14 tortillas. Do you think you could go down to 13? Only 13? Yeah, I can do that. Perfect, let's go down to 13. By the time they come back the next month, they're down to 12 or 11, because 13 was like, really? That's like nothing. But if I tell you to go down to 10 or 11, you're like, oh, I can't do that. I let you help make those choices. So I use your motivation to do things. And I measure your waist every single time, and you're down 1/4 of an inch, you're down 3/4 of an inch, and you're happy. You haven't lost pounds yet, but you're happy, and you're making better, healthy choices. Now we start talking about increasing the walking and changing something else in your diet. So we do it in baby steps. When you get to, after you've been with me for about 3 or 4 months, then I put you out for 2 months. You think you're ready for 2 months? Some patients say yes, and some patients say, no, I need to come in. I'm not ready to do this on my own. Okay, we'll schedule you back. So I start giving them choices. I never let them go longer than 3 months, but I do, and it's usually the younger ones that want to go 3 months, not the older ones. Anybody like after 45, all want to come in on a monthly basis. Younger than 45 usually want to get out to 3 months because they got a busy life still. Okay? And if I have kids under 20, because they have to come in with their parents want 3 months because it's their life that they're trying to figure out. But they do make changes. So then after we talk about it, we contemplate, we come up with our plans. So we've come up with our plans, now we're into the action where they're actually doing something. Once they start doing it, this is probably one of the longest parts until they get to where they want to be. And then it's just about maintaining it. You know, I can't walk every day for 25 minutes. But you know, I could do it 4 times a week instead, and I could do it for an hour. Perfect, you're doing the same thing, actually you added time to it. So we let them kind of make choices as we go along, as long as they're progressing forward, as long as they're happy, as long as they're maintaining it. And once a year, we give them that form and say, where are you today? That's all we ask them is where you are today. A lot of them say, well, don't you want to know where I want to go? Okay, you can put where you want to go. And it's 99% of the time, it's the same place they wanted on the first day. They don't want to be littler than that, okay? But they're realizing, and then I say, well, look at last year you were a 5 and today you're a 4. You've made change. And then again, so we become their cheerleaders for them as opposed to not having them do anything. All right? We also tell them that once they start at 3 months, you're going to probably have lost a 1/2 inch. At 5 to 6 months, people are going to say your face is skinnier, and it is. And we say at 9 months, they're going to say, where'd you lose all the weight? How'd you do it? Because now the weight's coming off. Even though you're tightening up, it's getting tighter. They see you getting smaller, but then they notice the pounds. So we tell them this is how it goes. And so they come back and they'll say, you're right. They notice my face was skinnier. I don't think it's skinnier, but they do. You know, I got to keep going. So it's, again, another motivating factor. We don't say, okay, next month you'll have lost a pound. We don't say, no, I want you to lose 4 pounds. If I tell a male to lose, that you're going to have to lose 10% of your body weight, he's lost it by the time he comes back in a month. Because men drop weight like, I don't know how they do it. But the problem when they do that and they don't lose the inches is 3 months later, they've gained that 10% back plus. Because did it, done it, can go back to my old ways. They haven't learned the pattern. So we have to think about it from that way. All right, apply key motivational interviewing strategies in the 5 A's framework to treat obesity plans. It's really about what you do. It's really about asking open-ended questions. Don't say, you only ate 1 egg, right? No, how many eggs did you eat? How'd you make them? I mean, patients will come up with interesting ways to make new foods so that I can share with the next patient. Can I use that and tell some other people how to do that? Yeah, you can do that. Okay, Thanksgiving's coming up. So right now, the patients are like, you know, God, we really want that pumpkin pie. We just, you know, how are we going to do this? You know, and I said, well, you can do this much pumpkin pie. No, that won't be enough. Okay, so I want you to go get yourself a box of spice cake mix. I want you to get yourself a can of pumpkin, small one. I want you to mix them all together, and I want you to put them in a cup muffin pan. I want you to cook it for, I don't know, 350 for 15 to 20 minutes. I don't really know how long. So you got to stick that toothpick, make sure it comes clean, and then take them out and let them get cooled off. Okay, now you can have a muffin every day, and you're going to get the pumpkin pie that you want. You can actually have 2 if you want. Why? Because it's a Weight Watchers recipe, and it's only 2 points. Okay, all it is pumpkin and spice mix. There's no egg, there's no butter, there's no nothing. Okay, and they say, oh my gosh, that did cure that pumpkin pie need. Because most of the time people don't want pumpkin pie. They only want it in November. Okay, maybe December too. So again, you give them other things that they can. And one of my patients came in and gave me that recipe. Okay, it works. And it takes what they want. And oh, by the way, the cake mix only makes about 17 cupcakes. So the worst thing you can do is you have it for 8 days. And I tell them to pop them in their freezer, to keep about 4 out, pop the rest in their freezer, and they can pull it out in the morning if they want. Of course, when it comes out, it's frozen. It takes a while to defrost. My patient says, don't put it in the microwave because it makes it really dry. So I tell my patients, pull it out in the morning, pull it out the night before so you can have it the next morning. And they're happy with that. Okay? So you want to do reflective listening. Man, it sounds like it's really going to be hard to get rid of some of that rice and beans. You like them both so much. Yeah, I don't know. So, okay, so let's open up your hand, make your cup, put a lid on it, put as much rice and beans as you can get in that cup. Now, that's about 1/4 cup. So you can either put it in your hands and stuff it, which some of my patients like the feel and the texture to do that because it makes them think. But others will get 1/4 cup and put it in there and smash and smash and smash, which they don't get very much. But you can have a 1/4 cup of rice, 1/4 cup of beans, or 1/4 cup of mixed, whatever your pleasure. Now, some of them will say, it's just a little bulging over on the top. Okay, the goal is to get it to be flat. That's it. That's all I say. And they'll get it down there. Okay? But then they get what they want. Okay? With my Asian patients, rice is a big deal. Okay? So we got to get that rice down because they have rice for breakfast, lunch, and dinner with whatever else they have. We have to elicit change talk. So how are we going to change? What do you think you can do? And it's always, what do you think you can do? It's not what I think you should do. I think you should do a lot of things. But the reality is they have to go home without me. Now, I'm lucky enough that I have an extension on my phone. I have a work phone. I get patients who call me on the weekend. I'm at a wedding. Let me show you the food they have here and what can I eat. Okay? I'm at a party. What can I eat? I'm trying to be good, so I got to show you the food. Or I'm going to tell you the food. They actually figure out how to get a hold of me on my personal phone because that's just how life is. And I get to see all these food things that people eat. And I said, that looks like a good one. That one looks like a good one. Oh, that one I would really like to eat, but it looks like it probably has too much whipped cream in it. And they'll laugh and they'll whatever, but then they eat better. And I said, just get yourself one of those small plates. Don't get the big plate, get the small plate so you can have little bits of a lot of things. Same thing, Christmas is coming up. Starting December 1st, my mantra will be, take 4 cookies. Cut them in 4s. Take one out of each of those 4 cookies, and now you've had what you wanted. You wanted 4 cookies, you got 4 bites of 4 different kind of cookies, and you got 3 days left. Okay? And they go, it works. Now sometimes they'll say they eat 2 days worth of cookies at one time, but they don't eat the 3rd cookie. So it's not like they have to eat 4 cookies. They have bits of cookies, so they get rid of that urge that they have to have. And they're happy because they feel better, because they realize and if they do eat the 4 cookies, Dr. Anna, I don't feel so good today. Okay, why? I ate 4 cookies yesterday, and it just doesn't settle well in my stomach. Yeah, probably a little too much sugar. So here's what you're going to do today. I need you to eat some extra nuts without salt. I need you to eat some extra chicken. I need you to have extra protein. Let's get rid of the sugars. So it's a little bit more protein-based today. And then go back to eating your protein breakfast, lunch, and dinner. Go back and having your vegetables at lunch and dinner. Go ahead and have your piece of fruit whenever you want it. So let's kind of get back on the roll of things. And then they'll call me back 4 days later. That really worked. Yeah, it works. Okay, so next time, let's cut those cookies in 4s, and let's just have one of each of the 4s and do it for 4 days. Okay, I learned my lesson. Okay, but again, it's about having them figure it out. But they'll call me and tell me when they don't do well. I get lots of phone calls for that. All right? Affirmation, you're doing a great job. I am one of their biggest cheerleaders. Oh my gosh, look at you have lost 1/4 of an inch. Now, did they really lose 1/4 of an inch? I can't tell you. It could be measurement error. Okay, I don't know. But as long as it says it like they lost 1/4 of an inch, I'm like, yay, 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 because that gets them going more. How do you feel? I think I have a little more energy. I'm more likely to walk now. Perfect. I went to the grocery store the other day, and there were 3 spots. One right at the very front, one that was about 4 down, and one that was about 8 down. So where'd you park? I parked at the 8th one. Why? Because I got to walk more. Now, how many of you would call your doctor to say, I walked more today? You're not. Okay, but they'll call me to tell me that, or they'll come into the office and tell me that that's what they're doing. That's something they figured out all by themselves. I didn't tell them to park at the end of the parking lot. I just told them to walk more, but they're now looking for ways to make things better for themselves. Okay, and that's what it's all about. It's making them feel better. By them making, especially if it's a woman, or a man, not a kid, but a woman or a man, if they do it, they're getting their families to do this too. Okay, who cooks, mom or dad? Okay, in families it could be either one. Most of my families, the mother cooks, but I have a fair amount of families that the father cooks in as well. So if he's changing his habits, that means the rest of them are, because he's not cooking 2 meals. Same thing with the mom. She's not cooking 2 meals. They're cooking 1 meal. All right? Exploring importance and confidence in the readiness to change ruler. It's really about, when are you ready to do it? Are you ready to start walking? Are you ready to start going to the gym? Now, some of my patients say, I'm really tired of walking. What else can I do? Well, let's go walk at the beach. I practice in San Diego. I have to say that. I practice on Coronado Island for the most part, or in Chula Vista. And I have the ocean within footsteps of my Coronado office, and I have a little bit further in my Chula Vista, but there's lots of ocean down there. Go walk on the beach. Get your feet wet. We can do that? Yeah, you can do that. But people don't think about, to do that. I have to say that I walk out at the end of the day, if I'm in Coronado, and the beach is right there. Do I take the opportunity to go walking on the beach? No, not usually. Why? Because I'm too lazy, or I'm too tired. Okay? But if we decide, as whoever's left in the office decides we want to go to eat, we walk to the wharf to eat, and then we walk back. And then we usually get salads when we're there, so we eat healthy. But we walk over there as opposed to just driving and driving home from there. So we make a conscious effort to do those things. All right? And then summarizing at the end of your visit, what did you do? Okay, so we talked about your food. You've decided that you're going to have only 13 tortillas, and you're going to continue to walk, and you're going to walk so you sweat. Perfect. Anything else that we missed here? And then they say yes or no, and we summarize it, and then we give them their plan. So they have to buy into that plan. I can't make a plan. I can make the best laid plan, and it's never going to work. All right, we have to ask the good questions. We have to communicate respect, like, well, you haven't lost enough weight, you're still fat. Probably not a good thing to say to your patient. Help give patients a sense of control and collaboration. Asking permission can be as simple as it is okay to talk about your weight. Okay, we need to talk about your weight today. We're talking about your fatty liver, but we need to talk a little bit about your weight. Is that okay? Because they're in there really for me for fatty liver, because I'm the hepatologist. But the issue is I ask permission to do that. I don't just say ignore it. I don't just talk about their fatty liver and then I compartmentalize their diabetes and compartmentalize. No, we talk about how it all fits together. Okay? Open-ended questions encourage patients to reflect and give thoughtful answers. Foster a discussion rather than an interrogation. Okay, I weighed more. I will admit, I weighed 20 pounds more, okay? And I decided I needed to lose weight. I'm still in the process of trying to lose weight. But the issue is I do what I tell my patients to do. And they're looking at me like, how come you look different? I'm doing what I've asked you to do. No, you're not. What did you do? I'm doing what I asked you to do. I'm walking. That's what I do. I walk. I go to the gym twice a week, and I walk the rest of the time. I take stairs if I have an opportunity to take stairs. I eat better. I eat healthier. Yes, do I still have a piece of cake or a cookie or something? Yes, I do. But I also eat more protein. I also eat more vegetables, and I eat a piece of fruit. Fruit was like my biggest thing I never really did. I like vegetables, so that was not a problem. Protein's not exactly what I care about, but I'm eating more of it just because I wanted to prove to my patients this is what I can do. I tell them at 5 o'clock, if you're on Coronado Island at 5 o'clock, you want to go for a walk, come on over and I'll go for a walk with you on the beach. And I do. I walk with them if they want to come. But they have to come to me. I'm not going to go to their house. Okay? I have a lady today that wants me to go to her house in Chula Vista, pick her up, and bring her to the office. Not going to happen. And I told her that. Okay? Reflecting your understanding of what the patient is saying and trying to say. If I don't understand it, I'm going to say, I don't get it. I don't understand what you're trying to tell me. Now, I have to learn. I have patients in Spanish. I have patients in Arabic. I have patients in English. Spanish I get pretty easily. Arabic, I know words. Okay? And so, but I always have an interpreter with Arabic. Okay? But you can tell by their mannerisms a lot of what they're saying. At least I have figured out how to do that. And so then I'll just turn to my interpreter and say, this is what they said. Yep. And the patient will go, yes, that's what I said. I go, if you can speak English to me. And they go, no, we're more comfortable in Arabic. Okay, that's fine. Okay? Because they do. I mean, it's the same thing. Even a lot of my Spanish-speaking patients can speak English. They just are not as comfortable in it. That's fine. I'm not comfortable in theirs either. So I'll say some words and I'll go, I have no idea, but here's it in English. And they go, okay, we got it. Okay? So you don't parrot. You said this. You said that. No, we're not parroting them. Okay? We're taking what they said and interpreting it for them or thinking what we think they said. Requires clinician to hear the patient, interpret what the patient is concerned, and then reflect their understanding back to the patient. I hear that you said da 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 da. All right? I think this is what you're saying, and here's what we need to do. Or here's what you want to do, and this is why it will work. Or this is why it won't work. So I'm all about educating my patients all the time. My doctor calls it the warm and fuzzies. And that's what I do. And it's like, okay, how can I do all of this in a 15-minute visit? You can. Not the first time or two, because the patient doesn't know who you are. But once they start to trust you, you can get through this. I have them fill out a paper that says what they ate for the last 24 hours before they even see me. Why? Because I can skim through it really quick and see if they've changed or not changed. Where I can fix it, where I can't fix it. Hey, it looks like you're eating a lot of tortillas at dinner time. What's going on at dinner? Not why do you eat them? What's going on at dinner? Oh, it's because it's just easier. We can just throw some cheese on it. We can go da-da-da-da-da, and we're done. We always have that in our house. Okay, so let's find a better way to do that. What can we do differently? So give them some ideas, okay? During change talk, patients' voices, the reasons they change are that are personally significant for them. I eat this because I'm really angry because I've had a fight with my husband, my boyfriend, my family, whatever. Okay, so what other ways can we handle this anger? So we become a counselor too, rather than stuffing your face. Okay, what makes you think you need to change? How would you like your current situation to change? What will be different if you started to eat healthier? What's the worst thing that could happen if you started eating healthier? Well, I'd lose weight. Okay, so what's so bad about losing weight? Well, then I won't look like my family. That always has thrown me, like I won't look like my family. Never dawned on me like those kinds of things. All right? So we're working through those things. Affirmations, statements made by the clinician that recognize the efforts, the progress, the value of the patient. I walk in and I say, oh my gosh, look at Sienna, you've lost some weight. Look at your face, it's so much thinner. And they're like, they don't know what to say because no one's ever come up to them and said those kinds of things. There's like, oh, you're still overweight. No, look at you, you've done so good. So I'm really good about doing that with my patients, and I think that's what they appreciate about it, is that I'll come up and I'll say, hey, it looks like you're really sad today. What's going on? Not, why are you here today, which is what I should ask them, but why do you look so sad today? Oh, well, you know, it took me a little while to figure out how to do something. And then you just kind of, that changes your conversation. I get it, and I can bring them back in. Okay, so how are we going to deal with this? How are we going to make that as a learning lesson? No, I'm not going to refill your medication. I don't do that. You're going to have to go to your primary to go do that. All right? I don't take on what I can't take on. All right, exploring the importance of the patient ascribes to a health change behavior goal and confidence they feel about achieving it. So again, asking the patient, what do you want to do? You know, Anna, I don't want to do anything this month. Okay. When do you think you want to get back on board? Should we have you come back next month, or do you want to have a 2-month break? You'll give me a 2-month break? Yeah, I'll give you a 2-month break. This is your life. My job is to help make you feel better. My job is to make your liver better. So I'm ready whenever you're ready. And that really throws patients when you say that, because no one's ever said that to them. Okay, I have an alcoholic patient right now who has ASH, which is called alcoholic steatosis hepatitis. He's got a real huge fatty liver besides he drinks alcohol. And I said, you know, sir, you're going to have to stop drinking. Or first I said, how much are you drinking? He says, oh, I'm only drinking two pints of vodka every day. Okay. Now, that's a lot, okay? For those of you who don't know alcohol, that's way too much. And I said, so when do you think you want to stop? I'm not. Okay. You know that if you continue this, your platelets are already 40. You know that your liver enzymes are sky high. You know that you have all these other issues. You know that this is going to cause you to die. Okay, I'm going to drink. I'd rather be dead than give up drinking. Okay. I literally turned my back and said, what can I do for you, to his wife. And he says, hey, wait a minute, I'm the patient. I said, no, you're dead. You want to die. I'm going to allow you to do what your plan is, but I need to make sure your wife is okay. And he just kind of looked at me. And I said, and he goes, I said, I need you to go ahead and I need you to eat protein. I need you to keep up your strength. I need you to have some vegetables. She doesn't drink, okay, and I need you to go for a walk every day. And he goes, well, what about me? I said, well, you need to do the same thing, but you want to drink. And I said, and that's okay if that's what you want to do. So he says, well, I'm coming back next month without my wife. I said, okay. So he came back next month. His wife came with him, and because she's not ready to go. And he says, I'm really angry with you. And I said, why? He says, because you're going to allow me to die. I said, no, I'm not allowing you to die. That's your choice to die. I'm telling you, if you don't want to die, this is what you need to do, and this is how you need to eat and get better and make your liver better. And he goes, why doesn't anyone else ever tell me that? You're the only one. And I said, probably because I care differently than most people care, and I will honor your wishes. When you're ready to change, you will let me know, and we will fix this. Okay, I've now been seeing him for 6 months. He no longer drinks at all. He's eating protein breakfast, lunch, and dinner. He's eating vegetables. He looks great. He still has cirrhosis, but he's doing much better. So sometimes you have to make sure the patient's ready. It's not what I want. I mean, I went and as soon as the visit was over, I called my doctor and I said, Dr. H, you're not going to believe what I just did. And I said, I had to do it because he doesn't understand. And he says, no, it's okay that you did what you did. He says, you made a point. And then when he came back the next time and said I made a point for him, I called him back and says, guess what? It worked. He goes, but I don't think I use that as a regular way to do things. I go, no, I don't use it. I said, but I got desperate that this guy just didn't care. His wife is sobbing, I mean, literally sobbing in my office because he won't give up any drink. And he wants to die. And he's very clear about the fact he'd rather die and drink than give up drinking and maybe live. Because I can't promise him he's going to live anyways. All right? So again, it's about checking out where your patient is and where they are and when they're ready to change. When they're ready, that's when they're motivated to do it. That's when you make your impact. It's not that I don't document that I did this. It's not that I don't document that this is the plan I'd like him to be on. It's not that I write what his response is. So summarizing, you have to move from one topic to another, shows the patient that you are listening, which can strengthen your clinical relationship, and it's used to reinstate treatment developed by the patient and the clinician. Nothing works unless the patient buys into it. It's all about the patient. It's all about the patient, always about the patient. You can do the best you can do, but if the patient doesn't agree with you, it doesn't work. In pediatrics, what happened in pediatrics is if I put a patient on antibiotics because they had an ear infection, moms are wonderful for the first 3 to 4 days. And then the kid feels better. And then we kind of start to miss a dose here, miss a dose there. On the phone, hey, how's the antibiotics going? Are you still giving them to him? He's probably feeling great now. He is. I don't think he needs it. No, he needs it because we need to get rid of all the residual bacteria. Oh, okay, thank you. Making that phone call got me another 3 or 4 days of antibiotics. Okay? It's because you care about the patient. It's about the patient. You all take antibiotics. You last 3 or 4 days as well, and then you kind of miss a dose here and there. Most of you don't take your 10-day dose consistently. So again, having someone calling up and saying, hey, I care about you doing this makes a difference. Is it time on my part as a clinician? Absolutely. I have a list of patients I have to call every day for whatever reason. Some days I have nothing to call. Like Sundays, I don't have anybody to call because I don't see anybody on Saturday. So it's perfect. All right? All right. Required and mandated by sentence for Medicare and Medicaid services. So this is what you have to do. If you deal with Medicaid and Medicare patients, you are required to document these things in relationship to obesity and probably for everything else that you do. Number one, you have to assess. You have to assess the complications and the risk factors that they have related to the obesity or the problem. So she has diabetes, she has cholesterol issues, she's BMI of 42, those kinds of things. Contributing factors is that this is what her diet is. It's high in carbs, very little protein, does no exercise. I assessed it. Okay? I document it. I have to then advise the patient, you know, we have all of these things going on in here. Your diabetes, your hemoglobin A1C is 14. That is way too high. That means your blood sugars are consistently over 500. You're doing damage to your, we know by research that you do damage to your eyes, your vascular system, your kidneys. So what we need to do is we need to start working through some of these things so we can get it. So I am going to send you to an endocrinologist. He's the better person to do this. He's got all the lucky drugs and stuff like that. I have lucky drugs too that I can use, but I'm going to have him do another better assessment of it. If she goes, no, I'm not going to go, my insurance won't pay for it, okay, I'll manage it. I'll get a fasting insulin as well, and then I will start manipulating drugs. I use a lot of GPL1s. I use a lot of Victoza, a lot of Byetta. I use a lot of Saxenda. I use a lot of Lantus. I don't use a lot of insulin. I don't like sliding scales, and I never use glipizide. I tell the patient I have to order you glipizide. I order them 5 tablets. I put it on there for 2 days. I call them up and say, it doesn't work, right? And they go, no, it doesn't work. Perfect. Document it doesn't work. I tell them they have to tell me that. Okay? I tell them exactly what, because glipizide gives them too many hypoglycemic episodes. Okay? That is worse than having them hyperglycemic. Okay? And so, because now they think they have to diet because they're not eating all the diet food that they're supposed to eat, whatever, and now they're hypoglycemic all the time. Oh, I feel like crap. I'm sugar, I'm shaky, I'm diaphoretic, and I got to go through all the hypoglycemic stuff. So I just tell them, you get 2 days, I'll call you up and tell me it doesn't work, so I can put you on the real stuff. Because the insurance company requires me to document I tried it. I'll give you a 2-day try. That's it. Okay? I have to be very clear, very specific, and very personalized. So if I'm going to change a lot of your insulin meds or a lot of your diabetic meds, I'm going to call you in a week. I'm going to have you come back in 2 weeks, but I'm going to call you within the week. Make sure you're doing okay. Check on you just to make sure you're doing okay. What is a good day and a good time for me to call you? And I write it in my book. Call Sienna at 2 o'clock on Saturday night or afternoon. Okay? I tell them I don't call after 9 o'clock at night, and I don't call before 7 in the morning. So I put parameters on them because I'm not going to have them call me. But they do call me at 2 in the morning if they're in trouble. All right, agree. You collaborate with the patients on a healthcare outcomes and treatment goals. Okay, so we're going to go ahead and we're going to try this. This is what we're going to do. You're going to have a protein for breakfast, lunch, and dinner. I have to document that. I have to document that you're going to have vegetables at dinner and lunch and dinner. You've agreed. A lot of times I make my patients sign my chart, and I give them a copy of the note so everybody knows what I said. Okay, I get my notes done because we do electronic. I get it done right away, print it off, give them a copy, make them sign it, and then scan it back in the thing. So I have 2 notes for the day. 1 signed, 1 not signed. Okay, and I do that if I'm concerned enough. Assist, I help the patient to achieve agreed upon goals by acquiring the skills, confidence, social environment, and support system behavior for change. Assist in assessing resources and providers. I don't know everything in Chula Vista. I don't know everything in Coronado. I know a lot more than I used to know, but I don't live there. I live in Upland. Okay, so I go down there and I get those little throwaway newspapers and I read what's going on in the towns these weeks and whatever, so that I have an idea. I've been to the YMCA in Chula Vista. Okay, I've been to their grocery stores because my patients were telling me that they don't have this stuff in the grocery stores, and I'm like, really? People really don't have good green vegetables in the grocery store? I went to the grocery stores, and they're right, they don't have them. So then I went down on the weekend, so I go to those food fairs that they have. So I went down there and said, okay, let me go see what I can do there. So now I talk about food fairs, because I went down there and I went to them, and some of the stuff is reasonable, some of it's way too high, and I tell them that they have to shop and you have to know what the local stuff is. They don't like going out of their blocks of whatever they've created for themselves. They want to stay in that little environment. So I can't get them to go somewhere else and go to a better grocery store. They have to stay there, so I got to get them to go to the food fairs. Okay, but once every 3 to 4 months, I go down there to figure out where the food fairs are, so I can tell my patients. I mean, it's nice I get to drive down to Sandy. Oh, and then when I do get to go to the beach, and I do walk along the beach, and I do all those fun things, and we take the dog, and we have a great time. But the issue is that I don't do it normally when I'm only down there 1 or 2 days a week, okay? But I will get them to help me. All right, now they tell me. They bring into me all the list of all the stuff of where everything is, which is great because then I can post it, and we post it outside, so the patients can all look at it. All right, schedule follow-up visits to provide ongoing support and adjust the treatment plans as needed. I have my patients come back every month to 2 months until they've got an established plan. Once they do, then they can go 2 to 3 months. But I always ask my patient, what would you like? I let them have that control. They know themselves better. I know what I need at certain times that I need to be, somebody needs to watch me right now because I'm not going to do very good unless you'd like to have watching me. So, and I know that about me, so I think that about everyone else, and I think you are capable of making those things. The challenges to shared decision making is health literacy. Are they able to understand what I'm saying? Okay, everything's written at an 8th grade reading level, but if you don't read 8th grade, then it's useless to you. So we have made some of our own stuff and our own things. In our own practice, we have lots of picture stuff. Okay, and then we go in and we circle the picture stuff we want you to eat. We have nutrition pamphlets we want you to use. So we do a lot of those things. I draw them pictures, I give them papers, I have them write, I write underneath them. If they write in Arabic, because I don't read Arabic at all anywhere, however, I have the person who does read the Arabic tell me what it says so that I can correct whatever it is that we need to correct. Okay, does it take longer? Yes. Over time, it takes less time. I invest early so I reap my rewards later. All right? Insufficient training, if I don't tell them, they can't do it. Okay, a lot of them say, well, their doctor said lose 10 pounds, but he didn't tell me how. He just told me I had to lose 10 pounds. I don't know how to do that. So my job is to teach them. Insufficient reimbursement, that's an issue for the provider. That means you didn't code correctly. And we'll talk about coding in a minute. Inadequate information systems, you just don't have available to you what you need to have. You have to, as a provider, go out and figure out what's in your community. This is where your patients are. You need to know what they do out there. It's get out there, sometimes show up, be available in the community. You have to be careful of HIPAA, because I can't go, oh, hi, Sierra, how's your blood pressure today? Which she's got a bunch of people around her, or I have a bunch of people around me. But I can say, hi, how are you? Now, if she wants to talk to me about business, I'll pull her aside. If she wants specifics, I can't give it because I don't walk around with a walking chart with me. I don't have a clue. You know, I don't know if her blood pressure is the same as her blood pressure. I don't remember which ones are which. I just know that she's had blood pressure issues. And so we can do those kinds of things. So I show my face out in the community. All right? Inadequate or lack of follow-up processes. Do you make an appointment? And what happens if they don't show up? What is your system to getting them back in? Who do you call? Who calls for you? I haven't seen a patient in 6 months. Why? Where is they? Where are they? I had a patient that I hadn't seen, and I knew that I was supposed to see him. So we tracked him down. He's up in Northern California. He says, I've moved to Northern California. I come down in the summer and spend it down there with you guys. Okay, perfect. So what are we doing up in Northern California? Well, this is what we're doing. Okay, have your provider send me a list, and I'll give them what I have. So that, and then I'll get it just before you come back down so that we can have this conversation. All right? Objective number 4 is describe weight bias and how it affects the obesity treatment. It really does impact your clinical approach. It limits your reimbursement, and it keeps patients with obesity from seeking health care, resulting in increased morbidity and mortality. The bigger you are, the less you want to be seen, in most cases. So does your office make it so it's inconvenient for them to come in? Do you put all your chairs have arms on it? If they can't get in a chair to sit because the arms are there, what do you do with them? Do you have open chairs? We have benches, we have a couch, we have chairs that have arms on them, we have open chairs, we have a variety of chairs for people to do whatever it is that's more comfortable for them. Okay? But so it really does, I said, oh, well, today's fat clinic. Well, that doesn't put a big happy smile on everybody's face. It may be what it is, but that's not what you should say, because what if a patient overhears you? What if your employee is overweight? And they're going like, what do they think of me? Okay? So you have to remember those things. So what is bias? Bias is against those who carry extra weight. How do you look at people that are overweight? Are they just people, or are they overweight? Are they fat? Are they disgusting? Are they lazy? What do you think about them? Bias based on false assumptions about the cause of obesity. You don't know why someone is obese. Now, if you're sitting there watching them stuff cake in their mouth, and that's all they're doing is stuffing cake and cookies and regular soda, you can probably guess it's a nutritional problem. But it may not be. It may be the prednisone that they're taking that's causing them to want to eat everything under God's creation. And you don't know why they're taking prednisone. Maybe they have PBC. Maybe they had a flare-up in their gallbladder. Maybe they had a flare-up in their pancreas. Maybe they have autoimmune disease and that's why they're on prednisone. You don't know, but you just made an assumption that this person is lazy and eats nothing but wrong food. You don't know that. So you've already had a bias against them. Explicit and intentional or implicit and unintentional. Oh, there she comes. Okay? I mean, your face tells it all, whether they're good people or bad people. So you have to learn how to have a poker face or always have a smile on your face or something. My patients will say, Anna, you always are smiling. You always make us laugh. I said, that's my job. I said, being sick isn't fun. So I might as well make you happy before you leave. Okay? Obesity stigma is a major issue and the latest socially acceptable form of discrimination in our society. Okay? Watch TV. Okay? You got skinny, skinny people. Now you have a lot bigger people on TV right now that are saying, well, I'm big is beautiful. And that's fine. Okay? It's not exactly what you weigh that's the problem. It's what it's doing to your body, if it's doing something to your body. Some people are bigger bone. They're going to be bigger. They're not fat. They're just bigger because their bones are much bigger. That doesn't make them fat. But you have to learn how to figure out how to accept and not accept people. And if you're in a practice that requires you to accept people for whatever they are, then you have to learn how to be that way, no matter what button it pushes for you. And allow that to happen. You can't make them feel worse because they came and saw you, because they don't want to come and see you. Again, we look at dietary changes, we look at increased physical activity, we look at lifestyle changes as the cornerstone of obesity treatment. It may be taking you off your glipizide, and then all of a sudden you drop a bunch of pounds. Okay, you weren't intentionally trying to be overweight. It was your medicine that made you overweight. I have a lady right now on 60 milligrams of prednisone. Okay? She gets to go to 50 this week. Oh, she went to 50 on Tuesday. All right? She's still got umpteen weeks because her liver enzymes are still really high. They're still 900. Okay? They're 900 because she has a chemical reaction to something in the environment. We know what it is. And we've removed her from that environment, and her numbers are coming down dramatically because they were 1,800. Okay? So we're down to 900. So we're in half already. But the issue is and she's like huge, and she says, I just can't stop eating. When can I come off my prednisone? You can't yet. Your liver's not ready for that. So here's what we're going to do for you. So we've given her other things. She comes in our office, and we give her an apple. We cut it up for her. We put raisin faces on it. I mean, just to be funny. Okay? And it sounds kind of funny. It sounds kind of cute. But we do this so we can show her different ways to eat healthier food, even though she wants to eat all the time. She doesn't like celery. She doesn't like raw carrots. We've actually gone back and put carrots in microwave and brought them out so she has soft carrots. We bought her a thing of baby carrots the other day, gave her a jar of baby carrots. She thought that was hilarious. Okay? But we can do that with her because she's part of this, and she brings us really funny foods too, so it's the same thing. But we do this because it makes it easier for her. She has to come and see me every single week to see what her liver numbers are doing and if I can decrease her. Now, if she's still 800 next week, she still stays on 50. If she drops down to 700, I can drop her down. Okay, if they go up, I got to go up again. Okay, so this is a process. We've already been in this process now for 3 months. Okay, and she's on heavy doses of prednisone, and we're not taking her off for a while. Okay, so we have to look at it. We want to support whatever changes they want to make. You only want to walk? Okay, you want to come walk with me? This is when I'm going to walk. I only walk on Tuesdays in Coronado because that's when I'm in Coronado. I don't walk on, she goes, well, can't you come down on Friday? No, I'm not driving down from Upland to San Diego. I'm not going to do that. But you can go walk on the beach on Fridays. That would be perfect. All right? Behavioral skills and training, and then back to dietary change. So there's lots of parts to this. It's always a revolving door. It's always a moving door. It's always making little tweaks and changes. It's a process. We tell you, it took you over, according to you, 5 years to get to this weight. It's going to take us some time to get out of this weight. Now, usually the rule of thumb is 2 to 3 times longer than what it took you to get there. I don't want to tell her it's going to be another 10 to 15-year trial. I don't want to go there because she will get less than that before that, and she's doing very well at it. But again, it's a process. I tell my patients, again, 9 months is when we want to start seeing weight. And they're like, really? Yeah, we're going to have changes before that. And they're all excited. I mean, they come in, they start beaming when they know that there's been changes. I had to go buy new clothes. And they're like beaming from ear to ear. I can't keep losing weight. I've got to buy so many clothes. I said, this is when you go to Goodwill. This is when you buy only a couple pairs of pants and you just wear those pants all the time until you get down to a little lower weight. Don't go out and buy a whole new wardrobe every time you make a change. It does get expensive for you, so we won't want to do it. The environment, what's your waiting room look like? We already kind of talked about the chairs, place them at least 6 to 8 inches apart. You don't want them butt up together, so like if they have no arms, they're butt up, then your butt's hanging over on someone else's chair, then they don't like that. It's like being in an airplane. Consider specialized bariatric chairs with minimal seat width of 30, with a minimum of 30 inches, preferably 36 inches. We do not have any bariatric chairs in our office. I will tell you that. Don't display artwork and magazines that promote thinness as the ideal body weight. So we have magazines, you have to change them out every month or every 2 months because otherwise they're old, even though I'll still read old magazines. They don't. It has to be all new stuff. So if they're all got models on it that are super thin, that's not what you want in your office. So we have like Auto Mechanic, This Old House, we have HGTV, we have Better Homes and Gardens, we have Shape, we have some cooking one out there. I can't remember. Taste of Home is out there. So we have different ones out there, but none of them all show thin people on it on purpose. All right? Provide magazines and media that promotes healthy living, nutrition, and we already talked about that. And we have to have a scale that has a capacity of 700 pounds. Most of you have a standing scale that you've got to stand on really close because it's only this wide. And then you have to kind of like balance yourself as the machine kind of moves a little bit, and then you have the thing to measure your height on it. That only goes up to, I think it's 350 pounds. What do you do for the 400-pound person? You don't weigh them? No, you have to weigh them. So you need to get the bigger one that has like arms on it so they can actually hold on if they need to. It's low to the ground and get it. Does it cost more? Yes, but is it better for your patient? Yes. Everybody stands on it, not because you're overweight. Everybody, the skinniest of skinny and the biggest of biggest, all get on this, and it's 700 pounds. If I've got someone over 700 pounds in my office, I need a bariatrics person with me because they're way bigger than I can handle, and I won't be able to help them. Okay? But I have a bariatric surgeon in my back pocket that I can call. Hey, you know, and his name is Dr. Calorie. Okay, Dr. Calorie, I got a patient. When do you have a place in your office to visit with him? And he'll tell me. And it's all about the language. Avoid the obese patient. Instead, it's the woman with obesity. Education being the patient's first language. Their first language, not your first language. And adopt all clinical settings, people treating with obesity. Everybody in your office needs to be on the same page. That means the receptionist, that means the biller, that means the MA, that means the scribe if you have a scribe, it means all the students that are with you, it means all the providers with you, it means all the research people that we have a research component as well. So it means all those people have to not look at obesity as like, oh my gosh, what is wrong with her? How come she's so fat? Okay? Objective 5 is assessing current eating patterns, exercises, and personal preferences. Okay? It is really your preference when you eat. The timing of your meals and snacks. Okay? For those that came early, found out that Linda and I didn't eat breakfast this morning. Okay? And usually I do. I'm usually up at 6:30 and I have a bowl of oatmeal every single morning. That's just my routine. Okay? Then I'm good to go till 11, 12 o'clock. But when do you eat those meals? When do you eat those snacks? Why is that important? Because if I eat at 8 o'clock at night and go to bed at 9 o'clock at night, when do I digest my food? In the middle of the night. If I'm digesting in the middle of the night, do I repair my body? Absolutely not. Your body can't do two things at one time. Either that or the food sits in there and then in the morning you're like, oh, I don't feel so good because the food dinner is still in my stomach. Okay, so you need at least 3 hours before you go to bed. We tell people that after 6 o'clock you shouldn't really be eating. You can have a snack, a little snack, not a whole bag of popcorn with a bowl of ice cream and a Diet Coke. Okay, that's not a snack. When do you eat meals and snacks? Now some people say, I can't really eat that much. Okay, you can be a grazer. Grazing actually is better for you. So you have a protein in the morning, you have your piece of fruit out a couple hours later. You go ahead and have your protein again with maybe vegetable. You have some vegetables after that. You go ahead and have your dinner or whatever, and then you might have, an apple or a piece of fruit after that. Okay, you can eat all day long. Some people have to eat all day long. They do better eating all day long as opposed to eating breakfast, lunch, and dinner. Because if you eat breakfast, lunch, and dinner, they need to be equal times apart. Now the problem with that is, if you start at 7 in the morning, that means you're not going to finish until 6 o'clock at night, so you've got about 12 hours. That means 6 hours later you eat lunch. Okay, 7 to 12 or 12:30 is what lunchtime would be, and then from 12:30 to 6 you'd have no meal. Now, your body physiologically doesn't work that way. Your body has this thing called bile. And bile goes into your stomach every few hours, about every 3 hours. It can be 2 hours, can be 4 hours. And it goes in there whether or not you put food in it. The problem is if you don't put food in it, it builds up and gets really gluey. It's called sludge. Then when you go to eat that next meal afterward and you eat it and you're going like, I don't feel so good. It kind of hurts, kind of, oh man, I got a twinge over here on my side, whatever. That's the bile trying to push through the sludge. Well, the gallbladder can't do it by itself, so it has to have the liver help push everything through. So now you got this big push, this big stretch in your liver, a big sharp pain, and then you have some dull ache afterwards, and then you go ahead and digest your food. But if you ate every couple of hours, it works really well. It doesn't ever build up. Okay, so it's all about how you want to eat. So we tell our patients that, and they're going like, oh, let me try that. Oh, you know, that works. Perfect. Now, somewhere magically around 6, 7 o'clock at night, the bile just kind of shuts off. It doesn't work all night. It just doesn't, and it doesn't build up. It just kind of shuts itself off. So you have to think about that. Eating triggers. What makes you want to eat? Boredom, traffic. I got nothing better to do. I just need that piece of cake because I know it's sitting in that oven, in that refrigerator or on that counter. I just need to have it right this minute. Whatever it is, I'm stressed, I'm angry. Whatever it is, you got to know what your triggers are for eating. Okay? And you got to figure out what you're going to do instead of eat for them. Who prepares the meals and where are they prepared? Okay, in my house, most of the time I cook dinner. When I'm not home, my husband will cook dinner. On the weekends, it's fair game to whoever cooks dinner. Okay? And then once a week, we try to go out. That's just our routine. We don't have kids at home anymore, all right? So we can kind of do wherever we want to do. So we do a lot of stuff in our house. But if you don't, if you go out to dinner, who's preparing the dinner? What are they putting on that food? Now, I have a granddaughter who has an issue. She's had a choledoductal cyst. She has no gallbladder. It was removed. She can't have milk products. Well, she can have milk as long as it's low-fat milk. She can have cheese as long as it's just a little tiny bit of cheese. And like if you have scrambled eggs, you have to make them with water because people put whole milk in scrambled eggs otherwise. And she just like has a good time sitting in the bathroom with diarrhea. Okay, so the issue is who's preparing it? We have to ask them, whenever we take her out, we have to ask, how do you make this? She wants this to eat. Now she's discovered ribeye steak, okay? And she thinks that's the best thing since sliced bread now. So again, she can have that as long as they don't put all the salt and the pepper on it because it's too spicy for her. And then she gets the small one and her dad eats the other half or her mother eats the other half. But she won't eat the potatoes because it's too starchy for her, but she will have lettuce with it. But don't put any dressing on it because she doesn't like dressing. She could have a little bit, but she chooses not to have it. And bread, that is like her weakness. So we can't have too much bread on the table because she would rather eat that, and she would rather have the stomach ache from the bread and the butter that she eats than to not eat it. Okay, she's willing to have diarrhea from bread. Okay? Don't ask me why, but that's her thing. But again, so you need to know those kinds of things. How many times do you eat out a week? And where do you eat out? Do you eat at McDonald's? Do you eat at Olive Garden? Where do you eat on a regular basis? Because they, again, have different choices of how they make foods. You have to think about it. How much alcohol do you drink? How much sugary beverages? You can have a glass of wine. It's sugar. Alcohol is sugar. That's all it is, plus a few other things. But for the most part, it's really a sugary drink. And you're allowed to have some, but you can't drink the whole bottle of wine tonight. That's way too much. Okay? You can have a soda if you want it, but you probably shouldn't have 3 or 4 of them in a day. Okay? Again, it's all about what you do. What are your cultural and family influences on food consumption? Okay, I already told you, my mother, when I grew up, she put a plate on the table and you ate what she put on the plate because you had to eat it because of the starving children in Africa. That's what she always said. You have to eat everything. And we're just like looking at it like, here's a glob of potatoes, and here's a glob of vegetables, and here's a glob of this. And our plate was covered. Okay, and we're 8 and 9 years old going, we can't eat all this food. This is way too much. But we had to stay and eat until it was all gone because of the starving. At some point, my dad kind of like would take stuff off our plates, or other relatives would. Or then my mother thought, okay, maybe we should give them a dinner size, the cake size plate. And then we got that, and then we had to eat that, and then we could eat that. And if we wanted more, we could ask for more. Now, my house, when my kids grew up, and with my grandkids, we asked them how much they would like. You must have a vegetable. You must have a protein. And you can have whatever else we have, usually it's salad or something like that. And they get to pick. Now, as you get older, I have a 9-year-old granddaughter, a 7-year-old granddaughter, and a 5-year-old granddaughter. The 9-year-old has to have 2 tablespoons. Now, it doesn't have to be the heaping tablespoons. It can be a flat tablespoons because she's not a big mashed potato person. But she has to have 2 flat. So 2 flat is like a tablespoon or teaspoon almost. So she gets to have that. The 5-year-old only has to have 1 because of her age. Okay? They can never say they don't like any food. They have to have what both my daughters call a no thank you bite food. Okay? And a no thank you bite food is not just take it. No, it must be a bite of food. And so that's how it is. Now, Scotland is a little different because there are certain foods she cannot have because of her stomach. But so she gets away with a little, like she does not eat fried chicken. Fried chicken just destroys her. But my daughter found out that if she took everything off, took the top layer of the meat off, she could eat the inside part of the meat. Okay, so we have figured that part out. So now she has to eat fried chicken. Okay, which they don't have very often because she doesn't do it, okay? But again, so you have to look at that, okay? In my house on St. Patrick's Day, we have corned beef, we have cabbage, we have boiled potatoes, and we have boiled carrots. That is what we do at my house, okay? We have that Irish meal, the American Irish meal, okay? And if you don't like it, too bad, because that's what you're eating tonight, okay? So everybody's learned how to eat certain parts of it, okay? But that's just what we do, but you don't have to eat a lot of it. All right, barriers to healthy eating. It costs money to eat healthy, okay? Fruits and vegetables cost money. If you can't buy fresh, you buy frozen. Don't buy canned because it's all processed with lots of salts in it, even the low sodium one. Because if you buy the low sodium one, you're going to add stuff to it because it tastes so bad. So fresh or frozen. And that's what we tell our patients, fresh or frozen. We actually ask our patients to grow some of their own food. Okay, that's a real trend right now, so we use the trend to our advantage. If you have some plot, you can just have like just a little bowl of, a pot and put some seeds in it and grow some things. So again, it doesn't give you a huge amount, but it does give you some. All right, so we do those kinds of things as well. Physical activity is a vital sign. You should ask your patients what do they do for activity. We never think about it, but we should. It's on a day, how many days per week do you engage in moderate to strenuous exercise like a brisk walk? How many minutes do you engage at this? Some people say, well, I can't because my knees hurt. Oh, I've got a really bad back. I can't do anything. Okay, sit in your chairs. And so they sit, they're usually sitting in their chairs. But I tell them to sit down and put their feet to the floor. So pretend that's the floor because this chair's up high. I said, put your back on the back. And they said, okay, put your arms on the arms. Okay, I got it. Lift your legs. Now you are walking. You can walk as fast as you want. You can walk as slow as you want. The goal is to take your knee and lift it as high, and you're using these muscles, not your knee. If your knee hurts, you're doing it wrong. So let's practice some more. Okay, so we'll do that. Now, you have back injuries. You can lift your hands up over your head. You can lift them down to your side, and you can clap them in the middle. Then you go up, out, clap. Up, out, clap. When you get good at that, I want you to get some soup cans and do the same thing with the soup cans. If their back is not an injury, so I ask them to reach over. They don't touch the floor. They just have to reach over. Now they're exercising. When do I tell them to do it? I say, what do you do all day? I sit in front of the TV and I watch TV. Do you have commercials on your TV? Yep, every commercial you're going to do something. And so I get them exercising. Then all of a sudden they're able to do things. Oh, I'm not as stiff anymore. Oh, I'm not this anymore. Oh, I'm not that anymore. Perfect, we're working. Okay, and so that's what you want to do. Again, it's to increase to 150 to 100 minutes over 6 months. That's a long time. 5 minutes a day work is 5 minutes a day times 7, you're doing 25 minutes already, or 35 minutes. Go to 10, you're doing 70 minutes. Okay, so it's little bits. It doesn't mean you have to do a whole lot if you think about it. All right, there is no magic bullet. I don't have a magic pill. There are pills out there for losing weight. However, most of them have major side effects. So we tell our patients not to do it. We tell them to do it the old-fashioned way. You earned it on, you earn it off, is what we tell them. And so one size doesn't fit all. You can have alcohol, as we talked about before, and we tell them to have no sodium added to their foods. We teach them how to use garlic. We teach them how to use basil. We teach them how to use thyme. Some of them like turmeric. Turmeric isn't digestible, but that's okay. If you want to use it and it works for you and it makes you feel good, perfect. It won't hurt you. Okay, so we kind of do a lot of those kinds of things with our patients. We talk about what they eat. We always ask them, do you have a new recipe for me? The men don't usually bring recipes in for us, but the women will usually try to give us a new recipe. We find that when we group this clientele of our patients together, that when they're in the waiting room, we allow them to chit-chat with each other and give each other recipes. We put paper and pencil out there so they can write recipes down that they like. If I'm running late because I needed to spend extra time with Sierra today because she just needed some extra time for whatever reason, doesn't matter what her reason is, I had to spend some extra time, or they brought in a cirrhotic patient that was doing really, really bad, wasn't scheduled, came in, I got to deal with them, I have to have them admitted to the hospital. That takes extra time of mine, so that means the rest of you are all sitting out there waiting. We will go out there, I will go out there at some point, sit down with you. They will turn on country music because it has a regular beat to it. It's the only reason we use country music, is it has a regular beat. It doesn't seem to offend anybody. And we do chair exercises for one song. And then I leave, they leave the music on, and you see the patients continuing to do the exercises. Then they're all back chit-chatting again, and they forget about the time. So we will distract them in different ways and teach them different things at the same time. Now, some of our ladies and some of our gentlemen get up and dance. We don't really like that because we don't have a lot of room. We don't want them to fall. So we tell them that they could dance in place, so they can do whatever they want to do in place. Again, it just makes it fun. It's not your typical doctor's office. You don't find that doing in most doctor's offices, but we do it in ours. And we only do it when we have our NASH patients for the most part. Referrals, we have dietary. All of the insurance companies do have a dietary response. You can get a nutritional consult. Sometimes you have to work to get it. Your MA has to call, and call. Sometimes you have to call, and call to get it, but you can get one for them. We do have obesity specialists within most of your health insurance policies. So again, they will require them to lose 5% of their weight in 5 months before they'll take them as a referral because they want to see that they're making an effort. They don't want to just do a gastric sleeve or a gastric bypass without that. And then we do have bariatric surgeons that we can use as well. Objective 6, this is our last one, is doing our training and all of those kinds of things. It really does require a commitment. I kind of broke it out into the parts of the people that do things, the receptionist, but they could be the MA or whoever. They just need to be respectful. Sign in. Anything I can do for you today? Would you like some water? If that's what your practice does. Don't say, would you like the candy? And we don't put candy out there. If we put anything, we put something healthy out there for them if we do. The MAs need to be respectful, need to collect the data. They need to, we have to ask our patients permission to be weighed. Would it be okay if we weighed you now, or would you like it at the end of your visit? Not, do you want to be weighed? We never ask them that because everybody says no. So we say, would you like to be weighed at the beginning of your visit or at the end of your visit? Okay, and they'll say, well, at the end. Okay, so then I walk in and said, so I don't have a weight on here. How would you like me to know if you did better or not? Let's go out and weigh you. So I usually get it long before the visit's over, but we give the patient the choice. And usually if I say that, they don't have a problem. They said, nope. A couple of them will say, no, they said at the end of the visit. Okay, we'll do it at the end of the visit. I'll respect their wishes, but I will come and try to get it a little bit earlier if I can. Give patient the option of not seeing their results. So we tell them, if you don't want to see, just turn away. Okay, or we put our hands over so that they can't read it because ours is digital, so we don't cover it so they can't see it. And we will record their weight. And don't say anything about it, okay? The nurse, we go in, or the provider, we don't usually have a nurse, we usually have the provider. I go ahead and do the waist circumference if I need to have it done. I review their food and activity logs, and I provide their education. That's my job, okay? Doesn't mean I don't have a translator. All right, so we have codes. We have screening for obesity, it's a Z code. We have inappropriate exercise and diet, a Z code. We also can use, if you are doing dietary counseling, it's Z71.3. And if you are doing counseling for exercise, it's Z71.82. Okay, so we can put in those codes. IDC-10 codes change every October. Just FYI, I didn't know that. So they change every October. Most of them stay the same, but they'll add a few extra numbers after them and whatever, with whatever they're talking about. Just so you know. All right, we have obesity codes, we have diabetes codes, hypertension codes, hypertriglycemia, behavioral counseling, and reimbursement only if the BMI is greater than 30. So those people that are just overweight sometimes get caught in that catch-22, but they usually have diabetes and hypertension and cholesterol. That does not mean that you do not put the obesity code on there. That does not mean you don't put the overweight code on there or the normal weight code on there. Those just add to your billing and support it better. So if they're overweight, Medicare says you can't bill them for obesity, that's okay. I can still put the Z code in for, the E code in for overweight, but they have diabetes, that's going to be something else that'll give me some other coding. Okay, you're allowed 12 codes per patient. All right? So you need to know that weight loss is difficult. It's hard. It took you a long time to get there. It slowly creeped on. It's hard to get off. You have to respect the patient's values, preferences, and express their needs. Okay, some people just don't want to lose weight. Okay, that's fine. Let me just work on your diabetes then. Okay, inadvertently by doing diabetes, I will lose weight. They will lose weight because I have to change their glucose levels. Okay? I have to do coordinated integrative care. I have to be clear about it. I have to give them physical comfort. I provide emotional support. I involve their family and friends only at their request. Okay, I can't call up their family and ask them to come in. I have to say, you know, you can bring a family member with you. You can bring your friends in here if you'd like. That's okay. Otherwise, I'm violating HIPAA, so you have to remember what HIPAA says. I can't discuss it. If they bring people in and they're not on their HIPAA, I say, can I talk in front of these people? And you are, and I write your name in my chart. And I write your relationship to that person. Okay, so everybody's clear that you were in the room when I did it. Patient can give permission. Okay, continuity of care, and we have access to care. Okay, they get to come in as much as they want. Okay, implications is obesity is a chronic illness. It's not just a, oh, you overate issue. It's a chronic illness. It is defined as a chronic illness. It can be successfully treated. It's no different than any other chronic illness. Exercise is a medicine. I write a prescription for exercise. That sounds really stupid. I do not write it on I do not write it on my prescription pad. I do not write it in under electronically under my meds. We have a prescription that we have that has my name on it, has my office and my phone number on it, has your name, looks like a prescription pad without it being a prescription pad that says, must walk 5 minutes every day. Here's your prescription. Why? Because that makes an important value to that for that patient. Sorry, I have to do this, my doctor said. That sounds really crazy, but it works. If you give them, I write a prescription that says must have protein every meal, must have 1 piece of fruit a day, and must have vegetables with dinner and lunch. Or 2 meals a day, because sometimes people eat vegetables at breakfast. Okay, so I will write that. Here's your prescription. As crazy as it sounds, if you have a prescription, you're more likely to do it. Doctor's orders. And it makes a difference. And my patients will say, this has made such a difference when I go home and my mother cooks for me and says I have to eat all this stuff. And I say, no, the doctor says I have to have a protein, a vegetable, and a fruit. I don't have to eat this stuff. Now, the mother usually comes in the next time arguing with me, but the issue is it works. Or if they have their tamales are coming up for us right now. So I say for us because I get a lot of tamales now. So the issue is we take off all of the matzah and eat the inside. Okay? I mean, you always still get a little bit of the matzah, but you don't get a lot of it. So we have it, so because otherwise a lot of it is the corn breading that they put on it. That's the fattening part of it. You want the inside. And so I've gotten some families to change where there's more inside than outside. Now they fall apart a lot easier, but they will do that because they know that's a better choice. Okay, so we've made a difference. When we have kids, they've gotten in San Diego, and the San Diego School District called me 2 years ago and said, you have our students putting the fruit at the front of the line. Do you know how much fruit we're going through now? It's more expensive. I said, yes, but it's healthier. Because we had a group of kids that said the fruit's always at the back of the line. By the time they get there, their fruit plate's full, so they never pick the piece of fruit up. And I said, well, what are you going to do about it? And so the kids together, they all came in at the same time, and said, well, we could move it to the front, can we? And I said, that's a school district. I can't make that decision for you. I say, yes, I will write a note to ask for it done. You must present it to your school. They did. They moved it up front, and then the school district calls me and complains. Oh, well, too bad. So sad. All right. Remember, lifestyle intervention is the cornerstone of all obesity treatment. Pharmacotherapy should be considered as an adjunct therapy. We don't just say, okay, you're obese, go get a bariatric surgeon. Okay, because you still have to make your lifestyle changes when you're all done. It doesn't work otherwise. You can eat through a gastric sleeve, and you can eat through a Roux-en-Y over time. And then there's no alternatives for you. Now the obesity is front and center and yours to keep. We can't fix you because you didn't make the lifestyle changes. Well, you'll have to make the lifestyle changes, though, to get better. Okay? Any questions?
Dr. Hefner, so if weighing the risk versus the benefits and with other comorbidities with obesity, when do we know if a patient is a good candidate for like a refer for a gastric bypass?
Okay, first of all, they have to lose 5%, minimum of 5%. Their diabetes needs to be in control. And then you refer to the surgeon, and the surgeon will put any other restrictions he wants on them. We will talk with the surgeon after he sees the patient because he'll tell us what he needs us to work with. Okay, and then the person has usually counseling and a variety of other things required by the surgeon to go through. All right?
I've seen like weight loss centers, and I've heard other friends talk about vitamin B12 shots. Have you ever heard of that being effective? Is that something that primary care would do? What do you think about that?
Vitamin B12 does not reduce weight. Vitamin B12 gives you more energy so that you're more likely to exercise and do things. Okay? So the answer to your question is no, I do not prescribe vitamin B12. Okay? They still have to make all the lifestyle changes that go with it, unfortunately.
So my question is in relation to nutritional education for our patients. I know it takes time to get them in with a registered dietitian or what have you, but in the meantime, besides using something like MyPlate, what other resources would you suggest when we're trying to design a diet, especially for someone who's like diabetic? I know I've heard of the DASH diet, but is there anything that's more so for diabetics?
Well, the diabetics have the diabetic caloric intake diets. So you can use those. So what I tend to find that my patients don't follow them anyways. So what's the DASH diet about? The DASH diet's about not having sodium. So don't add sodium to your food. That's it. Potato chips are not naturally occurring. They have too much salt in it. Celery has a lot of salt, but I don't restrict celery because it's a vegetable, and it has a lot of fiber for it. So I don't restrict it. As far as the diabetic diet, we talk about how many carbohydrates per meal, and we talk about 40 to 50 carbohydrates. So we talk about reading labels. Okay? Now, if I say 40 to 50, I know that they're going to have 50 to 60. So if I say 60, then I know they're going to go to 70 or 80, which is way too many. So I say try to stay between 40 and 50, and you can go over a little bit if you need to. Okay? And that usually is enough. And I tell them to avoid all the stuff that looks like, if it's white and it tastes good, you don't get to eat it. Because that's what most of your calories are from. It's from the potatoes, it's from the cakes, it's from the cookies that all start out with white flour.
What about like sugar-free type foods? Do you have?
I allow them to do that. I tell them that, those are really just empty calories. So if they're really starving, that they can have those sugar-free without it. But I tell them that they really want the nutrition that goes with it. Okay? One of the other things is cottage cheese has a fair amount of salt in it. I do let my patients have cottage cheese a couple times a week if they'd like it, because some people, especially my older patients, grew up on cottage cheese, and to take that cottage cheese away from them is just, they're just going to do it anyways. So I might as well be upfront. You can have it twice a week. Okay? Mm-hmm.
Especially for the Hispanic population with the beans, I understand refried beans are obviously going to be a poor choice, but is there a bean substitution that would maybe be something to offer them instead?
They do like lentils. So lentils work really well. So when we talk about lentils, and we let them make soups out of it, however they wish to use them.
You talked about a lot of tools that you use and in your office, like the prescription for exercise and diet. What are some other, tools that you have for your patients? Like if you have a new patient coming in, are there, packets that you give them or logs, or what are some of those kind of helpful things that we can incorporate to help motivate them and help track their kind of progress and goals?
When they come in to see me for the first time, they fill out what they call a health questionnaire, which just says, what have you eat? What's your exercise patterns? How well do you feel on a Venn diagram from 0 to 10? How well do you feel? Okay? And then any questions you have for the provider. They also fill out what are their medication lists, because I have to know what that is, because a lot of times those medications aren't the right medications for them. And then I have to negotiate with whoever ordered them. I don't take them off of them. I negotiate with the provider. Okay? Because I think that otherwise I'm overstepping bounds, and I want this to be a team effort anyways. This isn't just me doing what I need to do. It's all of us doing the best for this particular person. I have them fill out this thing that's called a Stunkard. Now, this is copyrighted, so you need to know that. I have permission from the people that own the copyright to use this. It's easy to get. You just write to the University of Pittsburgh, go through their go through their image council and send a letter and ask if you can use it. It takes a little while because it gets fielded around a bunch of people. And then they'll ask you what you want, and I just write that I'm going to use it to identify issues with my patients. I'm using it for motivational interviewing. I'm using it specifically for obesity patients and fatty liver patients. I wrote exactly what I was going to use it for. I will probably use this in research as well and looking at a group of population of patients. And I wrote that. So, and they wrote back and said, you have our permission to do that. Just please make sure that you give us credit when you use it in any of your presentations. Okay? Not a big deal to do it. I then also give them something called a Pittsburgh sleep study. That again comes out of the University of Pittsburgh. It does come out. You need a copyright. It's also copyrighted, and you can use it. They allowed me to use it. I told them again, I'm going to do it every 6 months on my fatty liver patients because that's what I'm using it for, because they have a lot of sleep issues. And this breaks it down into sleep-related anxiety, sleep-related to not enough hours. I mean, there's a bunch of categories within it. We're just started it, so I'm not sure how it's all going to play out. But we just started doing that, so we're going to see how that does. Prior to that, I just said, what time do you go to bed? What time do you get up? How many times do you get up for? Why do you get up? And are you feel rested in the morning? Those are the 5 questions I asked them. But I've asked those patients questions to every patient in liver anyways. It's just part of my nursing NP role. That's what I'm supposed to assess. We just don't tend to do it because sleeping hasn't been high on our radar for things. But I think sleep plays a major part in stuff. But that's my personal bias. So I got permission to do this every 6 months from them. The other thing that I do is I give them a PHQ-9. PHQ-9 is required by Medicare. It's a requirement for Medicare for me as a specialty. They only have to do it once a year. But it's great for me. It's free to me to use. I don't have to get anybody's permission to do it because it's required from it. I use it because, again, obese patients and fatty liver patients are more prone to depression. This picks it up right away. Okay, I can say, hey, you came out of 17 on your PHQ-9. That indicates that you've got some depression. So what's going on here? Would you like me to get you a counselor? Oh, no, I'm only this way right now because my dog died 2 days ago. Perfect. I said, we're going to redo this again in about 3 months. If it's high then we're going to get you some counseling, okay? And, yep, that's fine. And then I have to make sure I do it again in 3 months because I told them that's what I was going to do. So there is situational depression that I don't have to respond to, but I write in my note the patient said her dog died 2 days ago, feels that this depression is related to the dog. And it very well could be. But in 3 months, if she still comes about as a 17, now we got some other issues going on. So I just refer her to counseling. You always, as a patient, have the right not to do anything. She could not go. I just have to make the referral. She says, no, I don't want to do it. And I don't make the referral, then I'm negligent. Okay? I'm negligent. I can be, if she killed herself tomorrow and I knew she was depressed and I didn't make a referral, then I'm in trouble. Okay? So you have to, again, know those things. If you take a test and you have them fill this out and there's a problem, you're responsible now that you have knowledge to take care of the problem. So if my patients come out with a lot of sleep issues, I'm going to get them a sleep study for sleep apnea because, again, obesity goes with sleep apnea. I may refer them to their primary or to a psychiatrist, depending upon why I think they're not. I'm going to test them for diabetes and insulin resistance because I can medicate or unmedicate for that. So I will do those kinds of things. Okay? So the tools, I think they vary depending upon what you're looking at or looking for. I always have lab tests to run as well. I never order a BMP because it doesn't have liver tests on it. So I always order a CMP because I need the liver enzymes to know what they're doing. Okay? Other questions? Okay, thank you.